Thanks for joining us for today's webinar from the Institute for Research on Poverty at the University of Wisconsin-Madison. I'm Hallie Leinhart, and I'll be your host today. Our webinar today will explore the topic of understanding and improving healthcare systems for Indigenous peoples. American Indian and Alaskan Native populations face chronically underfunded healthcare systems and health disparities. Today's webinar is focused on important study findings, solutions for healthcare discrepancies, and innovative research to improve individual and population level outcomes. To discuss these perspectives and topics, we are very pleased to welcome three distinguished panelists. First, we'll hear from Julia Interrante, who is a research fellow in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She'll present her research study findings on the Indian Health Service and its association with higher quality perinatal care for American Indian and Alaskan Native people. Julia, thanks for joining us today. Next, we'll turn to Laurel Myra. She's the director of Red Lake Nation's Mino Bimadiziwin Wellness Clinic in Minneapolis. She will share her experiences as a practitioner and researcher with insights and recommendations towards improved care. Laurel, it's great to have you with us today as well. And finally, we'll hear from Melissa Lewis. She's an assistant professor at the University of Missouri School of Medicine in the Department of Family and Community Medicine. She will present her work on evidence-based resources designed to promote culturally responsive care. Melissa, we're so glad you could join us as well. Please do note that the views expressed by our speakers don't necessarily represent the opinions or policies of the Institute for Research on Poverty or any other sponsor, including the University of Wisconsin-Madison. We have an hour today, and after we hear from each of our presenters, we'll spend the last 15 minutes or so for a live Q&A. You can type those questions in the Q&A box. We did get quite a few questions submitted as people registered, so we will be queuing up some of those as well. And I do hope that you'll feel free to participate in the chat. We'd love to know who you are and where you are joining us from today. And I want to let you know that we have closed captions enabled, so you can toggle those on and off at the bottom of your screen. We will be posting the recording of the webinar within a day or so, and you will be receiving a link by email if you registered for the webinar. And with that, I'm very pleased to turn it over to Julia Interrante.
Thank you so much. I'm going to go ahead and get my slides set up here. Okay. So, yes, thank you for that introduction. I'll go ahead and just jump into this presentation since you've already mentioned what some of my presentation will be about. So first, I want to thank our funders that supported this research, which was from the Robert Wood Johnson Foundation's Policies for Action program. So I want to start us off with some background information that I do think is important to just level set this discussion. So nationally, there are 5.2 million people in the US who identify as Indigenous. 40% of Indigenous people live in rural areas, both on and off reservations. This is a larger proportion of rural residents than other racial or ethnic groups. There are many beautiful and positive aspects of living in rural areas, but the reality of our healthcare climate also means that there's less access to healthcare resources, including access to reproductive and obstetric care. Indigenous people experience a life expectancy that's a decade less than the population as a whole and increased rates of chronic health conditions and diseases. These disparities also occur during pregnancy and birth, and especially for those living in rural communities. There are currently 574 federally recognized tribes. Tribes that are federally recognized have tribal sovereignty and are entitled to receive funding, services, and protections from the Bureau of Indian Affairs, including funds for housing, education, and healthcare, and that the U.S. government is legally obligated to support. It's important to also note here that there are tribes in the U.S. that are not federally recognized. This is impactful because it prevents these tribes from accessing a lot of resources and programs that would otherwise be available. So, to fulfill this treaty obligation specific to healthcare, the federal government established the Indian Health Service, or IHS, in 1955. IHS has been critiqued for failing to provide consistent access to high quality healthcare, limitations in the services it does provide, and past participation in reproductive injustices such as forced sterilization. Nevertheless, it remains the primary means by which the U.S. government aims to fulfill its obligations to provide healthcare for Indigenous folks. I also want to make a point here to explain that IHS is not actually health insurance, but rather a health service delivery system. And it provides health services for approximately 2.6 million Indigenous people in the US. Those eligible for receiving IHS services also often need additional forms of insurance coverage due to financial service restrictions affecting IHS facilities. And many IHS facilities actually lack birthing services. So, access to care is essential before, during, and after pregnancy. And ensuring financial access to healthcare through insurance coverage is consistently linked with health outcomes and impacts decision making in perinatal care. Perinatal care and screenings also facilitate detection and treatment of conditions that contribute to increased risk we see in these populations. Um, and again, while healthcare is a treaty right, often facilitated through the IHS, many Indigenous people do not qualify or cannot access IHS care. And despite evidence documenting the link between consistent insurance, access to care, and perinatal health outcomes, little is actually known about health insurance and IHS care among American Indian and Alaska Native birthing people in the US, as well as the relationship that health insurance and IHS access have with care use and quality before, during, and after childbirth, which is the purpose of the study that we did. So I want to give a little bit of background on the data that we used. So we used data from the Pregnancy Risk Assessment Monitoring System, or PRAMS, from 2016 through 2022. We examined 8 different outcomes of health insurance coverage and Indian health services access listed here. So it was private, Medicaid, Medicaid and private insurance, or uninsured, each with or without IHS. We looked at healthcare use, measured as attendance at any healthcare visit. Um, and also, our measure of quality was looking at the receipt of high quality care, which was measured as receiving at least 75% of the recommended screening and care components. And we measured each of these at preconception, so before pregnancy, during pregnancy, so for prenatal care, and postpartum. And then for insurance, we specifically looked at the primary payer for childbirth as well. So the largest proportion of American Indian Alaska Native people reported having Medicaid only without IHS during preconception, prenatal, and postpartum. Only 1/4 reported perinatal IHS access. Uninsurance or IHS access only without any other health insurance for Indigenous people was highest before pregnancy at 21%. And just under half of those without health insurance in this period did report IHS access. So this graphic is complicated, and I will explain why. So because the majority of IHS facilities do not have labor and delivery services, we were really interested in examining differences in coverage and access between the perinatal period, so for prenatal care, for both of these graphics, that's the columns on the left, and the primary payer for childbirth, which is the columns on the right. These figures display the differences in complexity for financial coverage during this critical time between Indigenous folks, so again, the full left figure, and white individuals, which is the right figure. About 1/3 of American Indian Alaska Native people had some combination of private insurance for prenatal care, and 28% had private insurance as the primary payer at childbirth. In comparison, among white individuals, those proportions were much higher. And then of the 3.3% of Indigenous folks uninsured without IHS during prenatal care, Medicaid was the primary payer for birth for 53% of those, while 21% remain uninsured during birth. So now I'm going to go into some of our findings specific to care, use, and quality. So these next set of slides are specific only to Indigenous people for which IHS access is relative. So care use was lowest during the preconception period at 62% for the entire population here. Among those who were uninsured prior to pregnancy, IHS was associated with a 16 percentage point higher care use. Among those who had healthcare visits prior to pregnancy, IHS was, among those who were uninsured, IHS was associated with a 10 percentage point higher receipt in the quality of care versus those without IHS. This figure now is specific to the prenatal period. So, among those uninsured prenatally, IHS was associated with 7 percentage point higher care use. And then again, among those with a healthcare visit, those with IHS more often received high quality care. This was, again, across multiple categories, not just among those who were uninsured. So it was associated with a 9 percentage point higher receipt of high quality care regardless of insurance. And then you can see from this figure that it varied based off of whether individuals were privately insured, had Medicaid, or were uninsured. And again, this is now for the postpartum period. Among individuals that had healthcare visits, those with IHS more often reported receiving high quality care, with about 8 percentage point higher receipt of care than those without IHS. So this isn't shown in these figures, but I did want to point out some additional findings that we had in our larger paper that's published. So when we stratified these findings by rural or urban county of residence, there were some nuanced differences that emerged, particularly for uninsured people during the preconception and prenatal periods, for whom IHS access in rural communities was associated with greater improvements in high quality care. We also dug in. I mentioned that our measure of quality was receiving 75% or more of recommended components, but we wanted to see if there were specific um, types of screenings or care components that was driving these findings. And we did see that it was really driven by screenings for intimate partner violence, depression, and work environment in the preconception period. Whereas prenatal and postpartum differences included higher quality with IHS access across most of the recommended components. So there are some really important limitations to these data that were used. We were unable to distinguish tribal affiliation or tribal enrollment. This is really important because the American Indian Alaska Native designation is both a racial ethnic identity and a political term with legal implications for tribal enrollment. Not all individuals who self-identify as Indigenous qualify for enrollment, and there is variation across place and tribal nations on eligibility requirements. We also were unable to determine whether the care occurred at a federally operated IHS facility, at tribally operated facilities, or at urban Indian organizations. Again, these are aspects that are not available in the PRAMS data. And we also were not able to examine out-of-pocket costs, deductibles, or limitations in choices in picking specific providers or types of services. So just in summary and some implications from these findings, we found that Indigenous people have limited access to IHS care around childbirth. Well, over half of American Indian Alaska Native peoples did not receive high quality perinatal care, especially before and after pregnancy. However, those with IHS access did have greater care use and higher quality care than those without. So this shows us increased funding for IHS and for perinatal services offered by IHS may be one strategy to improve health outcomes for Indigenous people, especially those who are rural residents and reservation dwelling. These findings also suggest that further expansion of Medicaid coverage may play an important role in improving maternal and infant health outcomes. And these policy efforts to improve access to care for Indigenous people should engage federal, state, and importantly, tribal entities to ensure that treaty obligations are met and health inequities are addressed. So I wanted to thank my co-authors who worked on this paper with me, and I will go ahead and pass it over to Laurel.
Red Lake Nation, and I'm the director of the Minnow Bima Diswin Wellness Clinic. I'm going to share a bit today on recommendations for improving healthcare with Native communities. Some of this information is based on some research that we recently published, both Melissa Lewis and I, who's also on the call, and others as well. So in this study, there are recommendations for improving healthcare as well as highlighting different inadequate health experiences and then successful health experiences. And then I'm going to share a couple examples from our clinic in Minneapolis, Minnow Bima Diswin Wellness Clinic. It means good life in Ojibwe. And I'm going to share a bit about the development of the mental health workforce at Minnow for short, and also on the use of community health workers for mental health education specifically. So our article, Understanding the Way We Walk Our Life, Indigenous Patient Experiences and Recommendations for Healthcare in the United States, was published this year, and it was based off of 20 Native American participants and focus groups. 15 of them were Anishinaabe tribes, mostly from the area here, obviously, Minnesota, Wisconsin, and then 5 Lakota participants. The participants were patients at a Minneapolis-based Native American clinic, and the themes that came about were related to their specific experiences, both at outside healthcare systems and also at healthcare systems or their healthcare experiences within the Native specific clinic. The article does talk about systemic barriers and structural barriers, and then also recommendations for improving healthcare systems. However, this presentation, we won't have time for that today. Ineffective health encounters. So these are themes that came out of the interviews, and the patients really expressed feeling not safe or not trusting in certain systems. A lot of times this was related to not having adequate communication with their provider, feeling like there wasn't really collaboration on the treatment planning, so that they weren't necessarily a part of that planning, or kind of were receiving more direction rather than being fully informed. That they also felt that there wasn't thorough assessments. They experienced racism, discrimination, and stereotyping, and just kind of overall described situations where they felt their providers weren't understanding their history and who they were as Native people. So then their improvements they recommended were very much linked to what I'm sorry, just one sec. I'm trying to move this box of pictures so I can see the slide. Sorry about that. Okay, I can't see the slide because the picture. Oh, let me see if I can. Yeah, I can't seem to move this. Sorry, y'all. Well, anyhow, I can remember it by heart, I suppose, to a certain degree here. But So awareness of, being aware of racism, that's something that they experienced was really important to them, mostly because some of the folks described feeling like this lack of understanding of them affected how they a lot of times treated them, as far as like maybe thinking that they didn't have the knowledge to be able to have input into their care, or understand their health situation. And we also had folks share really neat experiences of having the native language, acknowledged. So whether that's saying hello or using some common language, Ojibwe language in the encounter, really improved the experience for them, feeling like they were understood or seen, respected. So, and then they also differentiated between providers who, one person had talked about like living in the suburbs versus like living in the community, and that it was nice if they actually lived there, that they also had a different understanding of like maybe what they were going through, whether that is, systemic uh, oppression, or thinking specifically around like the George Floyd period. The I think in the clinics and things were boarded up at different points because it was, there were planned riots and things like that, so it was very stressful time during that period. So just kind of understanding some of the community, whether it be violence or stressors that folks experience. All right, sorry, I was able to move the box. Sorry about that. So just being able to feel like they're understood as far as their beliefs, whether that's like the mind body medicine kind of perspective of like integration of like their health, with the spiritual aspect. So understanding that, the culture and the spirituality is very important to the community and part of their health, understanding and healing. So recommendations for effective health encounters. This kind of is very much related to, the last slide, but it's some specifics. One that's jumping out to me, right off the top, is kind of the integrated care piece. So, having an elder in resident or having someone who does traditional medicines available to provide those medicines that are really important for people's kind of mental health and wellness, and establishing a long-term provider relationship really helps to build that trust. Folks talked about how they would really like native providers. However, I've even thinking about in the mental health space, native providers make up less than 1% of providers. So, a lot of times that's not possible, but that's where we get into thinking some of the training and things that are needed for providers working with the native community. And just some of this is kind of basic, as far as like they want to feel like they are a part of the process. They want to feel, pray like there's some praise and positive reinforcement, help with finding resources, respect trauma. Like that was a big piece that people talked about, as far as making sure that there was a certain level of understanding of historical trauma, and how that affects some of the policies that were detrimental to Native people, how that affects health today, and then the ongoing kind of oppression folks are experiencing, and how that affects their health today. So what does this look like in practice? I'm first going to talk here about behavioral health workforce. So we're really blessed to have a 90% Native provider at our clinic. I know that's very unheard of, especially given, the stat I just shared around therapists. But we've worked really hard to do that. We've implemented strategies to, get students while they're in training and really invest heavily in their training and development. And then, it's good for retention as well. So offering them a job right out of schooling, even paying them during their practicums. So we've gotten really creative about that, and having been able to recruit those providers. We also have an all Native frontline staff and support staff, which is also really contributes to clients feeling at home and having a safe place to come where they feel understood and respected. Trainings. So this is something that is really important to us. We really invest heavily in ongoing training and mentorship of our providers, both during that, not just during the practicum time, but also looking at what they're interested in doing for their ongoing development. So one of the things that we've done is not just train our own providers, but also train community providers who are working with Native clients or shared clients who don't necessarily understand the community or they're non-Native, which is the majority of providers out there. So Melissa, Lewis, and I and others developed an Indigenous health toolkit, which she'll share a little bit about today. But it's a 7-module training that helps providers to kind of understand how to work with the Native community and understand the history and things. You can read more about that in an article called Developing the Indigenous Health Toolkit. Community health workers is another strategy that has been really successful in improving health outcomes and sense of safety for clients. The community health workers generally are in the community, have been working with around medical issues. So it is a little bit unique that we're using it primarily with mental health. So really, focusing on their training to understand mental health conditions and how to address those. It has helped to improve the work that we can do as a multidisciplinary team and also the care coordination we can provide, because it's freeing up our providers, freeing up our care coordinators to do a lot more of that care coordination, education, but also allows us to bill for things that we haven't historically been able to bill for. Again, we've been able to have an all Native staff in the metro area here. And we did this by training our existing staff because we did have positions posted for a while that we just weren't able to fill to recruit someone from outside of our org in. So what we did was we trained housing case managers, our intake coordinator, and care coordinators because they do a lot of that education piece already. It allowed us to, just develop more of our staff. And then it's been the group model has been particularly really successful in helping not just the clients have like that peer support, but also has been great for revenue because a lot of the services, even thinking about like targeted case management and some other services that are very heavy with the education piece, you can't always do those in a group model. So that's been something that's been really helpful for building a sense of community, because we do have a 110 unit apartment building connected to that's a part of our facility or development. So we do have 24 clients within there that are engaged in our housing support program. And then also we help them get connected with mental health care as well. So that's a bit about that model. So I thank you all. It's an honor to be here with you today.
Hello, everyone. My name is Melissa Lewis. I'm a citizen of Cherokee Nation, and I live here in Tahlequah, Oklahoma. Let me share my slides with you. Okay. So I'm going to do my best here to connect with the Indigenous Health Toolkit to programs that promote health through Indigenous culture. And just maybe a quick review of what this Indigenous Health Toolkit is that Laurel mentioned. So this is kind of 10 plus years in the making. The Indigenous Health Toolkit is a toolkit that was created through a community-based participatory research project with 7 experts around Indigenous health. We also collected data, Laurel mentioned that a little bit, with patients and with providers, and we also worked with an elders advisory group. The first 5 modules cover things like cultural humility, social justice, Indigenous history, Indigenous culture. But I wanted to share a little bit with you kind of what this module 6 and 7 look like. Just check real quick. Okay. And so, and I usually get these questions like, what does this look like in practice? So I wanted to share some examples with you all today. One, in the patient-provider relationship, that's the focus of our module 6. We know that the relationships that providers have with their patients is very important to healthcare outcomes. And so one of our colleagues, Terry Maresca, put this lovely list together. And some things I'll just kind of highlight here for you have to do with how a provider engages with the community. And that's something that we don't hear about a lot. But Dr. Maresca suggests that people show up at community events. And again, this really can be, this is a suggestion not just for thinking about Indigenous populations, but thinking about a patient panel. What are the major communities? And are you engaged? Are you familiar with these communities and their culture? So to do that, Dr. Maresca suggests showing up at community events, learning about the history of the place that your clinic is, or your hospital is, or your nonprofit. Learn about the history of those communities. Learn about culture in the area, seasonal rounds, traditional foods, for example. Find elders and healers in that community and think about how they could be in a role that that they can mentor you or that they can collaborate with you. A trusted person in a community is a great person for any healthcare provider to know. And so also support preservation of natural and cultural resources. We'll talk about that in just a minute, but what is important to that community? What are those cultural resources that are really important to that community and learn why? Create cultural in-services. I think about maybe we could go back to Laurel later, but some of the things at the clinics that she's worked at and the Twin Cities, they've provided in-services for Indigenous people around cultural activities, making ribbon skirts, making moccasins, even full moon ceremonies, providing the cultural resources that the community is asking for. Okay, and then the last module in the toolkit is really about systems of care, really thinking about those larger policies and practices that trickle down and affect patients' health and well-being. So creating policies around structural safety, increasing accountability. Laurel talked a little bit about patient navigators, as well as creating opportunities for providers, learning opportunities for providers to engage in culturally safe care. And then also Laurel also mentioned capacity building. I like to think of this like systems of care as what needs to happen, what we talked about in at the kind of the clinic level, the patient to provider, but how do we make those larger policies? And I'm going to share maybe some examples of what that could look like. And why this is important, I would say early 2000s, we started to see some literature that demonstrated the relationship for Indigenous people who participated in their traditional cultural activities and positive health outcomes. That body of research has grown to quite big today, and the relationships result in improved academic performance, improved positive mental health, improved physical health, and reduced substance use. So one place that we can really start in assuming that we've done all those steps that Dr. Terry Maresca asked us about, we've gotten to know the community, we've gotten to know the history, is to answer this question: what is important to this community? And I try to do a little bit of a reflection on the places that I've lived through my life and through my career. And, I think about, I lived in Duluth, which seems to be not too far from a lot of you. And something that resonated for me and was a message that I heard a lot from Indigenous communities there was their concern over their environment, specifically copper nickel mining, oil pipelines, that sort of thing. And I was really impressed that the physicians at the School of Medicine there, they took up that advocacy. They really, they saw the power and privilege that they had as physicians in a medical school, and they used that to provide testimony to Congress. And I'll give you a couple of other examples here. So one that's really been on my mind lately, the communities in Northern California and the Coast Salish, an issue that's very important to them, that sometimes I think healthcare providers, we don't understand as well, is salmon, is one, well, maybe a couple of different species of fish. And what has happened that has prohibited the salmon, which is the building of dams in their community. And again, although this might seem very far off from the clinical work that happens day to day for many of us, I'm really asking for you to put that, think about what communities want, ask, follow the lead. The research backs up what Indigenous people say their needs are. In a book published in 2019, there was this relationship where the salmon decrease in relation to dams and other environmental concerns related to the increase of diabetes. So this is something that affects our patients, patients coming into our doors every day. And, some exciting news is that, recently, this is just a month ago, the removal of those dams, and then research finding that those dams have been taken down and the really important food source has returned. So, hoping this chart to the left will start to flip now. And this is really based on the needs and the direction of Indigenous people in the community, really knowing what they need for positive health and for the communities around them as well. A couple of other examples, a kind of my time living in Arizona, it became very clear for communities, Indigenous communities in the Southwest, such as the Dene, Hopi, the Tohono O'odham, and others, that preserving their food sovereignty and passing intergenerational knowledge of corn, beans, and squash was very important. A Pueblo school, I recently found out their curriculum for their kindergartners, their entirety is founded on corn, and that is the core of their curriculum. So just knowing that, the research that's out there on the importance of heirloom corn, bean, and squash is really incredible. Oh, I apologize. So this particular article, this is by Dr. Sarkar in 2020, says traditional plant-based foods of Native Americans with their rich source of natural phenolic antioxidants can be incorporated into dietary interventions to counter chronic oxidative stress, other metabolic dysfunctions such as type 2 diabetes, cardiovascular disease, and gestational diabetes. And they did these interesting comparisons between these heirloom indigenous corn, beans, and squash and what was on, what we can find in our grocery stores. And there was much richer, they were much richer in the heirloom varieties. And finally, I wanted to share for my tribe, Cherokee Nation, language is very important. Our tribe has put in millions of dollars to saving and preserving a language, which we have about 1,200 fluent speakers left, and their age is on average around 65 years old. And if you look at the latest data on life expectancy for American Indians, it's 65. So for Cherokee people, the importance of language and the immediacy of saving the language is very important. And we find again, diabetes prevalence is related to Indigenous language knowledge. And so I wanted to share with you, and the literature, a literature review that I was part of looked at this very topic and found that Indigenous communities that spoke their language were healthier, specifically around mental health, education, tobacco, suicide, obesity, and alcohol use. I wanted to share a program that I'm a part of. It's called Little Cherokee Seeds. It's a language program, but we have been monitoring the health and well-being of the mothers that are part of this language revitalization program and the teachers. We've incorporated many aspects of culture. Here's some of our traditional foods. There's some Georgia candy roaster squash, squirrel, wild onions. Culture is our curriculum. So our seasonal rounds, there's dyeing of baskets, harvesting foods. And what we have found is that over a year's time, food sovereignty scores improved, and the percentage of pre-colonial Cherokee foods that people have eaten has gone from about 19% to 28%. People's language, it's not on this slide, but language use at home and with their children has improved. And finally, what has been really exciting is to think about these other categories: social support, life satisfaction. We know these are important for total well-being of individuals, families, and community members. And positive mental health has improved. And that negatively correlates with depression and anxiety. So we're seeing that if we kind of follow community's lead, provide support in whatever role that we have, this health is certainly going to improve. So I will stop there. Thank you all very much. What down?
Thank you so much for giving us such wonderful information. I'm going to jump right into some questions. We had a lot of really interesting perspectives that I'd like to get to. So one audience member said, part of the work we're currently doing is part of a federal funding mechanism, and we're hindered in our ability to travel, as well as other recent changes in the federal healthcare landscape. Do you have any suggestions on how to maintain positive relationships in virtual settings, primarily quality improvement folks working with healthcare staff? So this, I feel like, is a very relevant question that can take us through all sorts of changes and challenges. I'm going to send this to Melissa first because you had mentioned the toolkit, and I think there was some in there around connection and kind of building those relationships, and then open it up to Laurel and Julia as well.
Yeah, I'll try to be brief here. I think it is a real challenge. I had a federal grant during the pandemic, and to use community-based participatory research was very difficult, especially in areas that don't have internet access, elders and folks who are, not as versed. And I will say we paused, like many did. We continued, but we probably lost some valuable voices, to be honest. So it is a real challenge. It really is. And, you know, as far as the Indigenous Health Toolkit, that is a toolkit that has been delivered at a few different sites. We have done in person, we have done hybrid, and we have done only online. So, yeah, I agree that might be a good avenue when you're thinking about quality care, training of providers.
Julia or Laurel?
I don't have anything to add. I think that was great. Thanks.
I can just reiterate like the challenge on the data side of it too, right? The data that we use for the study I presented isn't there anymore, not being collected anymore. Um, it's things like that that really needed to be expanded and improved upon. So I think it's really challenging at the federal level right now, but maybe looking elsewhere for connections and resources that are not federally based in this current climate.
Thank you. Laurel, you had mentioned the lower number of Indigenous healthcare providers, even though it sounds like your clinic has done a really great job of having staff and providers from backgrounds. What can educators and community members do to encourage and nurture this path for young people? And are there programs that you have witnessed that have given younger people a path towards working in healthcare and serving their communities?
I think that is a great question. And I think it's one that we're starting to see some more movement in, but I definitely think more can be done, especially, you know, I think about our, you know, dental clinic in Red Lake that we haven't had consistently had a dentist there for many years, and people have to travel 40 minutes to get to a dentist. So just thinking about efforts, I've seen people, going into the high schools and looking to trying to find, folks who'd be interested in maybe exploring dentistry or exploring behavioral health. I do think, just over the last, I've been a provider for about 20 years, and I have seen a real improvement in reduction of bias around getting or stigma, I should say, around getting behavioral health care. And with, a lot of the kiddos who, went through training or through therapy, 15 years ago, 10 years ago, a lot of them are, in training programs or, are interested in getting into the field of mental health. So I do think it is, more exposure, getting folks, in front of native dentists or mental health providers to kind of build their confidence and show that it's an opportunity and an option for them.
Great, thank you. Julia, you had mentioned, or your work highlighted the importance of high quality, well-funded care for Indigenous populations, especially as people give birth. But I think we're just interested in whether there are other kind of studies that look at the quality of care for different subpopulations.
I think that's a great question. My research really does focus on that, the perinatal period, so around the time of childbirth, but really focusing before and after too is really important. I think there are lots of researchers who do that work and do it in, I think, an important way that's not just like what I do is mostly quantitative research, but in qualitative, like very valuable qualitative discussions within community. I know there's some work on even looking outside of, I mentioned federally recognized tribes and the research there, but also non-federally recognized tribes. Again, my area is really focused on maternity care. I think one of the challenging things too with looking at this larger picture and the data resources to study it is the measures that we have for quality care are really limited. I really loved, again, what Melissa and Laurel presented, looking at different measures that aren't just these like standard screenings or aspects that don't exist in larger data sets. So again, trying to build up different ways of building that knowledge are important. So I know that didn't fully answer your question there, but yeah, that's my research is really focused on the perinatal period.
Absolutely. And I'll invite all three of our panelists to provide me with any research that they find to be that you find to be especially relevant and that our audience members would learn from and appreciate. And you can follow up and I will send those links as well if you want to do that. I'm going to close with just a question for each of you. And this is really around kind of the best practices and what we can all do going forward. So if you were to see kind of one change or one action item that people can do who are either serving Indigenous communities or want to open it up to serving better, what is a kind of first step that people can take that would be helpful and improve care? I'll start with you, Melissa, and then Julia, and end with Laurel.
Okay, that's a really hard question. And of course, it's not one thing, but that's a question we tried to answer when we created this toolkit. What we saw was that providers really wanted to provide good care, but are not knowledgeable of the history of Indigenous people, which relates to the trauma and the disparities people experience. They're not as familiar with their cultural needs and resources. So, maybe going back to the words of Terry Maresca and that list at the beginning, I think the most important thing people can do is learn about your patient population, show up at community events, and get to know the community.
Thanks.
I think it's some of the structures, right, that we have in our healthcare system where the funding is like really focused on short, quick, and doesn't allow for a lot of that time to interact well with patients and for the providers to be financially supported in doing that. And I think so, kind of expanding some of those systems to better support care for patients, particularly for Native folks as well.
Yeah, I would definitely suggest, getting into the community as well. I think is kind of the main way, making those personal connections with clients and community members really helps you to just to learn more about, the community and their current struggles and develop those relationships. Thanks.
Very good. Thank you so much to all of our panelists today. Thanks, Julia, Laurel, and Melissa. Thanks so much for sharing your time and experience and your research and your practice with us. I just want to remind everyone that we will be posting a recording of the webinar within a day or so, and you will receive a link with not only the recording, but the slides, as well as some other resources that we will pull together. And with that, I just want to thank everyone for taking the time today and for being patient with us through some of the technical difficulties. It was an excellent webinar and very valuable, as the audience members echoed in the chat. So thanks again to everyone and have a great rest of your day.
Thank you.